Members, we have got quorum and it's time to get started, so I now call the meeting to order. Agenda item number 1, information paper issued since the last meeting. There's none. Items for discussion at the meeting. The list of outstanding items for discussion and the list of follow-up action have been sent to members for reference. Please invite the officials to join us now. The next meeting will be held on the 21st of July. It's a Monday at 4:30 p.m. in room 3.
呢個成立中藥嗰個建議咁喺最後先講啲人走晒嘅嘞喎。因為一般我哋講法都係擺最後。一般都係擺最後啊。你先問下委員意見想唔想搬嘅時候？如果委員同意，我哋都可以。因為講聲嘅啫。一般都係擺最後算啦，冇搞嚟搞去，問下。咁歡迎副局長同埋各位。
Welcome, Under Secretary and your colleagues. We were talking about items for discussion at the next meeting. The administration has proposed that for the next meeting, 2 subjects should be discussed. A, redevelopment of Kwai Chung Hospital, Phase 1. B, the Hong Kong Code of Marketing and Quality of Formula, Milk and Related Products, and Food Products for Infants and Young Children. Findings of the consultation. Members, any comments for the 2 proposed items by the administration? A number of topics which were scheduled for this meeting have been rescheduled in the court as proposed by the administration. Review on the cross-cutter referral arrangement for public specialist outpatient services of the HA, mental health services for children and adolescents, mental health services for the elderly. Any comments? Ms. Helena Wong, are you saying that we are going to talk about the baby formula next time? Well, it's the Hong Kong Code of Marketing and Quality of Formula, Milk and Related Products, and Food Products in Infant and Young Children, consultation findings of this. Will the administration look into whether the milk, human milk has been contaminated? Well, we are now talking about what subjects will be covered in the next meeting. Maybe the Undersecretary can see if some information can be dug out on this subject, and if members want to propose items for discussion in future meetings, please inform the Secretariat. Item number 3, there is a suggestion from Ms. Wong, outline of research study on regulation of aesthetic practices in selected places. And now we've been given a framework by the research office covering the likely scope of the study. It has been circulated to members. Any comments? I'm grateful for the framework proposed by the research office. I hope the study can be completed by September. I would like to know whether we can get some information from South Korea. Maybe there's a linguistic limitation here because South Korea has a big industry of cosmetic surgery. Do they regulate the practice in any way? Can we ask the research office to conduct a research into South Korea? We haven't been able to get hold of a lot of information, but we know South Korea does have many medical incidents, but they resolve such incidents through out-of-court settlement. So we do not propose to cover South Korea because other places might give us better reference information. Well, we are not just looking for good practices here. We may learn from other places' failure or lack of proper standards. We understand there may be a linguistic problem here, but we do have some local people in Japan who were helping our ETO. Maybe the administration can ask their consultants on South Korea to give us some information. We'll take a look. Let's see if the administration can offer information to us. If the information provided is sufficient, we'll put it back into the outline. Ms. Priscilla Leung, we all agree that in regulating such practices, safety comes first. So we all want to learn from other places. I agree that South Korea is a good reference. From what we have been told, though their incidents are resolved through out-of-court settlement, the question is why? Is there a lack of legislative regulation and provisions? Or is it that both the victims and the alleged wrongdoers are willing to do this out of court through settlement? And there are many cosmetic surgeries or surgery centers there. So let's get some information from South Korea. But I do see a notable omission here, and that is the coverage will not be extended to the Nordic countries because they use a lot of they do make use of medicines such as Botox extensively. I hope more information can be gathered concerning the medical incidents. According to local operators, customers have switched over to medical clinics to consult doctors in view of the previous incidents. So they have made the adjustments themselves. So perhaps we can gather more information about some more countries. So what's your suggestion? European countries, Sweden. Not from this side. This is going to be done by our research office, Sweden. Please tell us.
I heard that they very often have to fly to Europe. Okay, we will revisit some European countries and see if we can incorporate some of their countries such as Sweden for reference. Madam Wong, pick one. Under 3.3, I hope beauty-related advertisements, the regulation and also consumer education should also be incorporated so that people understand more about beauty procedures or treatment concerning the efficacy or possible harm. Okay, so advertisement and education. I want to focus on the beauty industry. What we need to look at is beauty products and services. So we're talking about certain treatments, products, and services. So you have already jotted that down. Okay. Next item. Proposed regulatory framework of medical services, medical devices. Professor Chen. Thank you. Well, at the moment, medical devices are not subject to any legal restrictions concerning the sale, use, and distribution. In order to protect public health and ensure the benefits are brought forth by new technologies, we need to develop and set up a regulatory framework for medical devices. The Department of Health in 2004 already set up a voluntary medical device administrative control system to raise public awareness of the importance of such devices concerning their safety. Concerning the regulatory framework options, we have also done some assessment and studies. Concerning all possible impacts, we have also carried out assessment. In November 2010, the panel has been briefed on our proposed regulatory framework and also the possible impact on the industry. As requested by the Business Facilitation Advisory Committee, the administration conducted another study between 2011 and 2013 to further assess the business impact of the proposed statutory regulatory regime on the trade. The study showed that the stakeholders in general supported legislative or statutory regulations. We have balanced different views, including different stakeholders. We have also referred to international practices, and we amended the proposed framework. And now allow me to report to you the details. First of all, we are going to have pre-market control, post-market control, and also use control before the devices are launched into the market. We propose that there should be registration to ensure the devices are safe. And concerning Class 1 medical devices such as bandages, dressings, and surgical masks, they involve lower risk, and they are normally purchased in bulk. The traders are required, therefore, to notify the or not to have to notify the DFH. So Class 1 medical devices registration and reporting is waived. The relevant traders still need to register with the DFH. For example, in case of product recall, they also need to keep proper copies of lists of devices supplied in Hong Kong, and they have to be produced upon the request by DFH. We also ask the local manufacturers must meet certain quality assurance arrangements. We understand that most importers and exporters are SMEs. We ask them to meet the requirements of the quality assurance mechanism. As for the import and export of medical devices, we are a major hub for re-exports. So most of the devices are for re-exporting, and not too many of them are sold or used in Hong Kong. In view of the concerns about the amount of admin work involved and the overall lead time required for importing products, especially for fast-moving consumer goods, we now propose not to introduce any import-export licensing control at this stage. After the devices enter the market, the DH will establish a post-market surveillance system to monitor the safety, performance, and quality of medical devices in the local market, as well as maintain vigilance on medical devices safety alerts issued by overseas authorities and follow up as appropriate. Both local manufacturers and ARs are required to have in place a tracking system that tracks certain high-risk devices. It will be a mandatory requirement for the manufacturer and AR concerned to report any adverse incidents of medical devices to the DFH and to conduct investigations and implement remedial measures. The beauty industry has expressed concern over possible control over the use of certain medical devices. The Working Group on Differentiation between Medical Procedures and Beauty Services have also carried out some work concerning the use and possession of beauty-related devices should be subject to more stringent control. This is why the DFH is planning to commission an external consultant to carry out assessment and detailed study on higher risk devices. We are going to fully consult all the stakeholders, including people working in the beauty industry. Depending on the outcome of the report, we're going to consider which devices should be regulated and how they should be regulated. We would like to stress that when we formulate such a framework for medical devices, we will continue to ensure public safety and health and strike a balance between these elements and the operation of stakeholders. When we choose what to be regulated, or at the end of the study, by 2015, we want to report to the panel the outcome of the consultation study and details of the legislative proposal. Thank you. Any questions? Today we don't have much time, so perhaps 3 minutes. Perhaps more members will join in. Madam Wong? Thank you, Chairman. The TP supports the government's setting up of this registration system for medical devices. We hope that you can complete this exercise as soon as possible. People in the beauty industry also want the government to spell out which devices are medical devices and will be regulated. They do not object to the setting up of such a registration system or having such a framework for certain devices. But other than having a registration system for the import and use of medical devices, we also need to offer training. Under what circumstances will people become qualified to use and operate a certain device safely? These trained people, do they have to be medical staff? If you work in a beauty parlor, you're not a medical staff, and can you operate the machine? So what will happen to this training system for the staff? And how do we prove certain personnel as being qualified? Or do you require people who have gone through medical training? In that case, people who have not taken such training cannot operate the machines or the devices. So what are the locations are we talking about? Who are these people we are talking about? How to ensure that they have been trained to have certificates or qualification assessment? I think you need a whole package if you only register the devices without offering relevant training and assessment mechanism. It is not going to be very helpful in protecting people's health and safety. So can you tell us more details? Thank you, Madam Wong. Perhaps I can tell you some basic idea, capability, training, so on and so forth. I will try to explain, and if necessary, my colleague from TFH will assist me. When it comes to the regulation or regulatory framework, we focus on medical devices. Pre-market and post-market control of such devices will target the traders who have such devices. As for people who work in the beauty sector, well, under the Education Bureau, there is this qualification framework stating their capabilities, what they can do, so on and so forth. Most beauty surfaces or procedures are not invasive, and therefore they don't need to be regulated or intervened. So we are adopting this risk-based principle. And the principle spells out that if it is a high-risk device, in the next stage, we have already done this assessment on different businesses. We would like to carry out a study to see where we should provide special training in relation to the risk level. After the study is concluded, we can identify the high-risk devices and how we can regulate the situation. Next round, please. Madam McMahon. Chairman, we agree with regulations. For people's benefits, consumers' safety and health, it is important to regulate the devices. But we also understand in the beauty industry, there are hundreds of thousands of people who may be affected. We have been discussing this topic for quite some time. It seems that every time some people always object. I think you need to consult all the stakeholders when we talk about medical devices. Of course, you will consult the professional bodies and medical associations. But when you talk about beauty surfaces, perhaps you do not consult people in the beauty industry. So when you carry out consultation work, I think you need to focus more on the beauty sector as well.
I believe the other secretary would tell us in a moment that you have talked to so many representatives of the beauty industry. But if you look at the paper, paragraph 24 or paragraph 19, reference has been made to certain committees. Sorry, 25, paragraph 25, regulation, and also another committee. You mentioned trade organizations, trade associations, medical associations, and academic institutes. Apart from the large traders, we have also got many SMEs or individuals providing e-services. So can you just contact trade associations and claim that you have reached out to them? Can you find the operators? Or would you be allowing academic institutes to speak in such a strong voice that those from the trade will no longer be heard? As for the trade consultation, the question is whether the trade, the beauty industry was consulted. We're here to report on the outcome of a business impact assessment. We have interviewed 51 stakeholder organizations. Most of these are actually companies offering beauty services, and also they employ the service providers in the beauty industry. We understand that it's important that we talk to both trade organizations and practitioners, but since the study is on business impact, the 51 organizations are trade unions, trade associations, and so on. Next round, please. Mr. Albert Ho. Thank you, Chairman. I want to clarify a point first. The concept is not to differentiate between beauty service and non-beauty service. You look at the whole thing from a risk perspective. Of course, if it's a radiation, it's already subject to regulation. But there are devices used by clinics, for example, ECG machine. But you don't think there is a risk, so there's no regulation. Am I correct in suggesting that? That's correct. We now have a voluntary system to regulate medical devices. Different devices do carry different degrees of risk. The DOH is aware of the devices being used and the attendant risk. Well, there are different risks. Some are invasive. Of course, if it's a radiation, then it may cause injury if not used properly. But some devices have to be operated in a skillful way. It can be very complicated. And if a device is out of order due to lack of proper maintenance, and the use of such faulty devices may be risky. Is that also a risk? Do people generally knowledgeable about such risks? Chairman, you may be familiar with devices used in clinics. You mean in medical clinics? No, in hospitals. The pulmonary respiratory type of machine. How do you regulate the risk of such devices? We're not just talking about radiation. I've handled some cases myself. The patient suffered from certain adverse consequences because of the device was faulty. For example, an intubation process had been completed, and then it became defective. The device should have sounded a beeping sound to alert others, but it didn't, and after 10 odd minutes, the patient died. So the member is referring to risk, and there are different degrees of risk in relation to different devices. And of course, we can differentiate between invasive and non-invasive processes. And the other point is about how the devices are operated, or whether the devices are in order or are they out of order. And then we have to look at the training of the people who operate such devices, whether they can identify the untoward incidents. As for post-market regulation, we propose a system that if the device is faulty, we hope through this regulatory system, the Department of Health can notify the people so that faults or faulty devices will be made known to all. Are you going to look at accreditation of training? Are you going to look into how the devices are going to be properly operated? Or we have different levels of regulations. There are pre-market regulation, licensing, and then post-market regulation. It seems that you are targeting the devices rather than the operator. Yes, precisely. This is about regulation of devices. Dr. Joseph Lee, Chairman. The regulation of medical devices has been dragging on for a long time, and they are coming back in 2015 for legislative proposals. It seems that there's no way the stakeholders can agree among themselves. Some of the people from the beauty industries are against regulating Class 3 devices, and the medical sector does not agree. So I don't think there is any prospect of these people reaching a consensus. So what about the IPL machine, medical lasers, radio frequency devices? Are they not Class 3 devices? What would the government be doing in the interim? Or are you just leave things to the stakeholders, and then you come back to report in 2015? You should tell people in the beauty industry, if this is a risk-based approach, and if we're talking about Class 3 devices, how can the industry assure the public that safety can be achieved? And who are using these devices? The government has a duty to remind the relevant trades and industries to do the right thing. You cannot just say, I'll come back to report in 2015. Thank you, Dr. Lee. The regulatory system is now based on the framework because of we have conducted studies in the past. We are going to improve the regulatory framework before launching it. At present, the DOH has already implemented a voluntary regulatory system. I'll ask the DOH colleague to talk about it in a moment. And now we are in the final stage of assessing the risk with medical devices and the proper way of regulation. And then the entire regulatory framework will be launched. What are you going to do in the interim? That's my question, Chairman. Yes, precisely. I'm talking about what we are going to do in the interim period. The DOH, the Department of Health, has launched a voluntary listing arrangement for medical devices. We cover thousands of medical devices, and we look at the safety aspects of these devices. As regards the beauty industry, and it's said that they will continue to use them. We do know this, and the working group on differentiating between medical and beauty devices are aware of this. So we are now going to conduct one final study. As you can see in the paper, we have conducted many studies. We very much hope that this study will be the last one. So you're not going to do anything until you have completed this last study. Next, two simple questions. How about common contact lens? Would that be covered? And your so-called OK lens, you regard them as low-risk devices? And in the future, under your regulatory system, are you going to provide for some flexibility? Hong Kong is a small market, and some drugs are not registered. So when necessary, the drugs can be procured for a particularly named patient. The same can be applied to medical devices. The market may be, Hong Kong is a small market, so maybe a device is not registered and now it's required by a particular patient. Can the registration be done in a couple of days? Maybe we are talking about a cancer patient requiring some device immediately. So that's the second question. First question are common contact lenses, medical devices, and second, regulation and flexibility. In the proposed legislation, there is a procedure for applying for exemption. So if a device is a special one, serving special purposes, the Department of Health will be empowered to grant exemption so that the device can be used in particular circumstances. We'll make reference to overseas experience. Well, but there are countries, their markets are big markets, but Hong Kong is a small market. If in a particular case I need to have access or use a certain device, but it's not registered, maybe we are talking about, say, a cancer patient requiring the use of such a device in the coming few days or immediately. I'll ask DFH to supplement. Hong Kong is not a big market for medical devices. If individual patients require special devices, we cannot say that you do the registration first because the patient would have died by then. So we can grant exemptions. Of course, we need to be notified, but there will be no need to go through the entire registration process. And then we can grant exemption for a particularly named patient in the use of a particular device. We don't want the registration system to stifle the use of new medical devices or to deny patients of the use of certain devices because Hong Kong is a small market. How about contact lenses? Well, if contact lenses are mass-produced, not tailor-made any particular user, then they will be subject to regulation. So some are medical devices according to your definition, some are not. Well, unless you're talking about contact lenses made for a particular user.
But if this is mass production, just like what we can purchase in the market today, those are medical devices because everyone can purchase them. Madam Lamifan, I want to talk about Para 23 and 24. In the past 20 years, the beauty sector has been developing very quickly. In the past, people did not really care who can enter the beauty sector. According to Para 23, IPL equipment, for example, should be operated by healthcare professionals who have been registered. And Para 24 mentions that we'll refer to overseas experience. I think when it comes to employment, setting up businesses, the beauty sector plays a role in Hong Kong. So after the previous incident, people are now talking about medical treatments. So laser treatments that are provided by beauty parlors, perhaps one day after proper training has been given, beauticians can also operate those machines. If there weren't too many accidents in the past, can we nurture a group of people who obtain certificates? We're talking about technical skills that can be acquired, and these people can develop the industry further. In the past, they started as technicians and then eventually they become business owners. If we allow them to receive training, as long as they meet the requirements, they can continue on with the kind of work they enjoy. And we shouldn't just refer to overseas practices. I understand the mainland beauty business is also expanding very rapidly. I just wonder if we should also study them. Thank you, Madam Low. As you have said, the beauty industry mainly provides non-invasive treatments or services. And the risk on public health is very small. And therefore, we do not need to regulate or have direct intervention. I'm talking about a normal situation. When we talk about medical devices, we're talking about this risk-based approach. I understand that the VTC also provides training courses to them. And in this business, we understand that people are studying courses, and therefore we are not worried. We focus on high-risk medical devices today. We hope to focus on this aspect this time. Are you going to cover mainland China as well? Yes, we have heard you loud and clear. Next, Ms. Albert Chen. I would like to understand about the government's attitude. I want to know how high the standards are, or how popular is this? Perhaps you need to obtain a certificate first, or only medical staff can operate. Oh, there are no major problems. Perhaps some of the procedures can only be taken up by well-trained people. And there are different practices in different countries. Well, you cannot expect an engineer to operate a crane. If you want to operate a crane, you need to get the license to operate the crane and renew that license every year. But there is no crane that can only be operated by the engineer. It's the same situation concerning the beauty industry. Perhaps it is someone who is already in the beauty industry who can get further training, the outcome will be better than having a doctor do it. It depends on how much you understand the business. For example, you would argue we need engineers to operate cranes to make it safe, but in terms of actual operation or the reality, it is not logical. Just like beauty products. If you ask only doctors to apply them, doctors would not waste their time on beauty procedures because they can make a lot more money elsewhere. So you need a licensed person instead of an engineer to operate heavy cranes. We have to consider the actual situation. Any response? I will ask my colleague to talk about the risk level. Well, actually, if the device is operated on a person, we will consider how damaging it can be potentially. If it is popular, many people are using it, doesn't mean the risk level is low. It's just like physiotherapy. You need a doctor to refer you to a physiotherapist. But the machine is operated by the physio, not the doctor. And it's the same for people working in the beauty industry. When they get a license, they can operate the machine. Because we're talking about operation of long hours. Perhaps you can ask trained personnel to operate the devices, but also have a doctor to provide a prescription, or it is to be used under the supervision of the doctor, but not operated by the doctor. We have heard that advice. We will look at that. In the UK, they are conducting a large-scale review. Perhaps certain devices can be operated by different people. That is what they are looking at the moment. Mr. K.K. Kwok? I've been with LegCo for more than a decade. Back in the 80s, we started talking about regulation of the beauty sector, and today we are still dragging things on. It will only be completed in 2015 for the next step of the study. We're just talking about the devices, not the users. So I cannot tolerate this. So I want to ask the administration, when are you going to actually draft the law? What about the operators? When will they be covered? Are you going to do it right away, or you're going to consult any further? An accountancy firm has been commissioned. You said that the cost of regulating will drop from 2 billion to 600 odd million, and then annual expenses will be reduced to 599 million. I don't know how you came up with that figure, but I would like to ask you, how much or what is the value of human health? How do we quantify or qualify certain figures? Of course, the industry does not want to be regulated. It is true for every single industry, but we're talking about 627 million per year as the cost. How did you come up with that figure? And what about use control, which is the most important? If you're not starting in this area already, perhaps in 3 to 4 years nothing will happen. Do you have any real plans concerning licensing or regulating? Thank you, Dr. Kwok. The framework is already in place. As I have mentioned, the working group on differentiation has made some proposals, urging us to study in a more in-depth manner concerning high-risk medical devices. We need to identify them and see how we can regulate. So in 2015, we need to be working on the framework. We already have the foundation. We are just incorporating results of the study. In other words, we will start legislative work right away after we report to the panel. So what about 600 million odd? How did you come up with that figure, Director? Well, according to the consultancy study on the impact on business, we have considered different devices. If new rules have to be taken into account, perhaps a certain business will have to obtain a license fee or registration fee. Perhaps they need to obtain ISO and they need to spend on the qualification. It may sound like a lot, but when it comes to medical devices, we're talking about a huge number being used in Hong Kong. And there are many operators. So when you do the math, by adding everything, it looks like a huge figure. But towards the end of the paper, you find our annex. Because of the large number, we have done a division per device expenses. You can find the details in the 3 tables. Mr. Poon. Well, I heard that it is going to be completed in 2015. We have to wait until 2015 for the outcome of the study and the details of the legislative proposal. Are you talking about early in that year or later in the year? Do you have a set timetable for the legislative work? Thank you, Mr. Pan. We'll have to find a consultant, and we're now going through tendering. The study will last for about 6 months. Once the tendering exercise is concluded, we will start the study right away. So which month in 2015? Well, we have not yet concluded the tendering exercise, so we cannot tell you a clear answer. How long does it take to complete the tendering? We will follow the government's requirements and procedures. It depends on how many people would like to bid for the contract.
I
estimate that it will take 2 to 4 months. I hope we can do it quicker than that. Well, it's mid-June, so you need to award the consultancy at the end of this year, and then it will be completed in the middle of next year. Am I right? We'll try to expedite the process. All right, we have overrun, and we still have to meet some deputations. So please be succinct and precise, 2 minutes each. Dr. Helena Wong. In Annex 2, we have the previous consultation C study report. Can we be given the full report? This is just an extract. Am I right? Is Annex 2 just an extract or executive summary? It's entitled Business Impact Assessment on Statutory Regulation of Medical Devices. Is this the full report? Well, this is an executive summary. Can you give us the full report? That's okay. Soft copy will do. Okay, let's protect the environment. Please give us a soft copy. All right. I have a question on Annex 2. For example, paragraph 37 and 52. He said that the proposed move to restrict the use and operation of Class 3B and 4 laser equipment to register healthcare professional only is anticipated to increase the demand for these professionals and trigger a redistribution of these professional resources between the local medical field and the local beauty trade. Who make the proposal? You? Is that you? And if we propose the restriction of the use and operation of Class 3B and 4, there will be a redistribution of professionals in the medical field and the beauty trade. And also in paragraph 52, it's also stated that DH proposes to license business operators of Class 3B and 4 laser equipment and IPL devices, and also to restrict the use and operation of Class 3 and B laser equipment to the 12 groups of registered healthcare professionals. So it's true to say that you will not restrict the operation of such equipment to healthcare professionals? Well, that's the proposals from the consultants. I think they are doing another consultancy study. I don't understand these two paragraphs because they seem to be contradictory. Your proposal or the consultants' proposals? The consultants' proposals. So the consultant is proposing that the people who are trained in the beauty trade can also operate such devices. Yes. But we are going to do another consultancy study, and we'll take everything on board in making a decision. Of course, you may say that no one wants regulation, but it's not the view of the beauty industry. They want to have clear guidelines, and also they want to have their voices heard in the proposed regulatory framework. Well, the paragraph 37 contains the proposal from the consultant. But what about the paper? You provided the paper for this meeting. And if you are going to consult the trade, are you going to be restrict yourself to trade associations? And what about academic institutes? Are you really just talking about healthcare professionals? Well, here we are just talking about a preliminary idea about the proposed composition. But we have heard you, Ms. Mack. So apart from trade associations, you would also consult individual, frontline people in the beauty trade. And can trade unions and our trade unions be represented? And how about academic institutes? Would they be all institutes representing healthcare professionals? We're talking about just specific groups. We haven't decided who or which organization should be covered, should be represented. We certainly need consult frontline practitioners. We note your proposals. All right, please make sure that you have proper representation, because last time you set up the committee in the wake of the medical instance, and the representatives could not agree with one another. Next, we have some deputations attending for the next item, mental health policy and services. Please invite the deputations to join us.
香港社聯係冇嚟嘅，係咪？OK， 咁首先
First of all, I would like to welcome all deputations and individuals for attending this meeting in a discussion on mental health policy and services. And we have quite a big attendance, so each deputation or individual will be given 3 minutes to speak. And if you cannot exhaust everything you want to say, please be assured that your written submissions will be carefully noted. And also, please be reminded that your speeches are not covered by the Legislative Council Powers and Privileges Ordinance. In other words, you are to bear any legal liabilities of your own speeches. All of you are, I suppose, will speak Cantonese. If you want to listen to Putonghua or English channel, please tune in the right channel. Channel 1 is Cantonese, Channel 2 English, Channel 3 Putonghua. All right, please be succinct in your speech. The first one to speak is New Life Psychiatric Rehabilitation Association. We have Mr. Ho Ka-chun. Thank you, Chairman. I represent users and workers in New Life Psychiatric Rehabilitation Association. We'd like to make 4 points, and we hope the Bureau would consider them carefully. First is about support to carers and family members of the mentally ill. We have 7 ICCMW. We received last year 1,022 requests for help, or 35% of all the cases referred to us. Most of the family members and carers did not receive any social benefits to support their families. Through our contact and our assessment, our workers found out that apart from dealing with the mental illness-related issues, the entire family would also be subject to tremendous pressure, and they need suitable intervention and support. And we all know that support from family members is very important for the rehabilitation of the mentally ill. And there will be family problems if the family members or carers are not giving sufficient support. So in the integrated Center for Mental Wellness, suitable resources should be provided to start support services and programs for carers and family members, and also to teach family members and carers suitable skills to take care of their mentally ill family members. And we also want adequate attention paid to the need of the community. It's expected that 1 in 4 will be elderly person, and then a number of them will be suffering from mental illness. According to CU, the surveys, 9.7% of our population is suffering from some sort of depression. And in our 7 ICCMW, 27% of the members are over the age of 50, and 2/3 of them are between 50 to 60. Many studies have told us that elderly mentally ill patients are worse off than other elderly people in terms of self-care, and their bodies degenerate much more quickly. So I hope the administration would pay attention to the geriatric psychiatry, so that we can help these people to take care of themselves and to age at home. Next, we have Hong Kong Chinese Civil Servants Association Social Work Officers Grade Branch, Mr. Leung Kin Hong. I represent my colleagues in working in the SWD. I'm a psychiatric social worker. Hong Kong is not a good place to carry out rehabilitation, which is community-based, because Hong Kong is a crowded place, and many mentally ill people are living in cramped space, homes and flats, or PRH. And many of the cases that we have handled are really about asking for bigger or for relocating to another public rental housing estate because of the current flats they have are too crowded. If the living conditions are so bad and there's no interim housing arrangements for them, because the interim housing we have for the mentally ill is actually provided through PRH. It's not a good choice to move the mentally or the ex-mentally ill to the community without any proper interim housing. We understand the government has invested a lot in the provision of places. But the doctors may spend less time in hospital-based treatment, and more time will be spent on rehabilitation in community. I think we should ask the doctors to do some research. At present, the current duration of hospitalization is just 2 to 4 weeks. We must find out whether this is appropriate. We have more than 100 social work officers in psychiatry, but I have to spend 80% on paperwork to apply for various assistance, to ask doctors to fill in forms. I have 80 to 100 cases, and at least every worker will be dealing with 60 cases at one go. We have asked whether we can have some social assistance for paperwork, but the government has refused to do this. And they are saying that communication will not be effective for these people who are less qualified. And we said you should leave communication with the doctors to us, social workers. That there are different programs, CTI, CPI, but we're talking about the same group of healthcare workers. Not much has been invested in providing more healthcare workers. There are 3 more points in your submission.
Next, we have Mr. Chow Man-sheng. We mainly serve the family members. And Mr. Ho is talking about the needs of family members, and we are all very concerned about that. Family members need counseling, and they can also become frontline medical staff if they have sufficient knowledge concerning how to take care of the patient, how to deal with daily crisis. We'll be able to avoid tragedies in the society. In recent years, we have been urging the government to incorporate family members as targets of support. In the community, people thought that there are services given to family members. I can tell you they are only offered indirectly. For example, knowledge transfer, psychological counseling, or financial support, they are all lacking. So I urge the government to incorporate family members as targets of services and support. In the way forward, we understand that there's a shortage of frontline staff, and there are social workers who focus on quantity instead of quality. So perhaps we can change things around. We need to focus more on quality instead. I understand that there is a shortage of manpower. There should be a long-term plan to increase the number of social workers and medical staff so that service users get proper services, not superficial support. We also support the establishment of a long-term mental health policy in terms of promoting public education. If there is any labeling or stigma attached to a recovered patient, this person will find it difficult to be reintegrated into the community because their fear of stigma or labeling. So in terms of public education, I think we need to remove all sorts of stigma. Thank you. Next. Well, what haven't been covered is already here. Next, from Baptist Oikon Social Service, Senior Service Coordinator, Ms. Chen Sao-Kam. Thank you. I represent our colleagues, service users, and family members. In recent years, we've done 2 studies. One is about depression and anxiety among secondary school students, and also the pressure level for the family members. I would like to present the findings here for your reference and follow up. First of all, mental health for youngsters. In the past 2 years, we've conducted depression and anxiety studies among secondary students. 4,856 people were covered. They came from 16 secondary schools. 20% of them had moderate to serious depression, and 30% affected by anxiety. And such conditions would affect their growth as teenagers. We would like to raise a few points to enhance the level of concern over their well-being. First of all, there should be cross-bureau communication collaboration. There should be more relevant training for teachers, parents, and youngsters so that we can have early identification of students disturbed by these conditions. We need to provide targeted services so that the condition will not worsen, affecting the daily life or social life. Secondly, mental health should be incorporated as normal curricula for secondary schools. Right now, there's not much mentioning or courses concerning mental health. According to the survey, we understand that very often the students will try to run away from the problem because this is not really discussed in the curriculum. Thirdly, we need to have regular review or survey concerning mental health among our secondary school students so that we can allocate resources accordingly. When it comes to the needs of the family members, we have interviewed more than 300 family members. We see that they are already aging. The carers are getting older, and 70% of them live with the recovered patients. So hopefully we can provide urgent services for placement of the patients, and they also need in-depth services and support services because they would like to see a long-term recovery plan. We also need to provide more support services to the family members. Thank you very much. Next, from Center on Research and Advocacy, the Hong Kong Society for Rehabilitation Manager, Ms. Anke Hong. Thank you. We have been concerned about people suffering from long-term illnesses, people with disabilities, and elderly people. Today we want to talk about the chronically ill and people with disabilities concerning the mental needs. In June, beginning from the 2nd until the 14th, if you have time to go online, you would realize that 5 chronically ill people committed suicide. They were in Watford State, Aberdeen, Shanghai, Taihang, because they were ill, and one was also in Tianshouwai. One of them committed suicide by electrocution. The chronically ill face many difficulties in life. They are not always inside hospitals. Some people with kidney illnesses, Parkinson's disease, they live in the community. So their emotional health or mental health are under severe risk, and I think people with medical background would understand the situation very well. In 2012, together with CEO Hong Kong, we had this research. We interviewed 400 odd chronically ill people and their family members. More than half, 54% of them, had mild to moderate depression and anxiety, and among 190 carers, the burden level is very high. 60% of them face huge pressure. So we would like to urge the government to make more attention to the chronically ill people. Mental health is very important. Health issues also about public health. If we can allocate resources in an appropriate manner, together with the right policy and services, many tragedies can be avoided or prevented. Our government needs to pay more attention to this group of people because perhaps they are facing many problems in the community and we are losing out on economic power. The chronically ill need more case management. They need tailor-made services. Beginning from 2010, the Hospital Authority also started some services, but only benefited a small group of people. So the government needs to consider setting up long-term mental health policy and services so that you can take care of the chronically ill and their family members. The Bureau also needs to provide greater support at the community level and have case identification and prevention. The Food and Health Bureau should extend the existing services to specialist care clinics. Thank you. Next, Ms. Yang Sui-Ling. Thank you, Chairman. I want to say 3 things. The first one is about commendation. We have a shortage of medical staff. But if patients are beginning to hurt themselves, doctors would allow advanced booking to deal with certain difficult cases in a more flexible manner. And it is good news that more psychotropic drugs will be incorporated into the drugs list. Concerning specialist referral, we should not rely on the triage system. We should have early identification and prevention. When a mentally ill person becomes ill, perhaps this person will go see the doctor only 3 to 4 times a year. And we need to provide more services to them. The third point is about collaboration between the government and the private sector to address the pressure faced by patients. When it comes to expenses, if you go to a private doctor, not everyone can afford it. And there are funds helping the mentally ill to have drugs for free for a year. The government needs to do something to resolve this problem as well. Secondly, when it comes to consultation fee, perhaps we need to have a voucher system just like for the elderly people, perhaps 10,000 per year, or every time 2,000, and the person can see the doctor 5 times a year. Many people are concerned about the mentally ill consuming more resources in the government system. For those who have mild emotional difficulties, they can go see private doctors. We can provide subsidies to them. For family doctors, it will cost about 700 to 1,000. So the government can provide subsidies. They can see the doctor at night time or over the weekend to alleviate the pressure on public hospitals. We should have medical vouchers for mental illnesses. The administration will understand better about the number of patients and have better budgeting.
精神病康復者同路人小組嘅會員係陳國勝先生。
多謝 Mr. Chen Kok-sing from a concerned group of the mentally ill. We have been talking about a lot of figures. Let me tell you a story. A professor wants to clear up the shelf, the bookshelf. His granddaughter said, "I would like to do it as well." So they together work on the shelf for 3 hours, and it was done beautifully. So the granddaughter said that I was also involved, but if the professor were to do it himself, it will only take him 1.5 hours. So the question is, which is more important, the economics and harmony of the families? So turning back to mental health, We have 7 million people, 1/10 have mental problems. So 700,000 people are suffering from some kind of mental illness. So how can the government cater for the needs of the group of 700,000? You have to consider their integration, their life value. They have certain needs. Some NGOs are doing some mentorship programs to help, or peer support groups, rather. So maybe some of the jobs we have in the market are suitable for the mentally ill, or maybe we can have job sharing, because the mentally ill may not be able to withstand the pressure of long hours. So maybe we can ask two to share a job. DHA is now asking nurses to do the job of doctors in examination. This is not desirable. Doctors are professional people. They do have a specific expertise. We hope that the examination by nurses will be a stopgap measure. It should not make part of the system in the long term. Next, we have Mr. Hui Wai Chun, not chair. I'm a social worker. I'm not a lawyer. I've been working with the mentally ill for a long time. I wanted to take a look at the wider policy issue. Many have spoken on the resources. The present strategy is crisis-based. We respond to crisis. We may have a lot of nurses, doctors to monitor, to observe the mental state of the patients. And if there's a crisis, the patient is taken to a hospital for treatment. Of course, this is a very quick solution if we are dealing with a social problem or community problem, but it's not very effective in dealing with mental illnesses. The government may look at the symptoms, the physical symptoms, and it's not very effective. We have a number of tragedies. Many of these people had problems of various sorts, mental, physical, and financial. And if you only deal with crises, you cannot handle all of them. There's no end to it, because delays can also cause a mild case to degenerate into a serious one. If you look at the community-based support, there are only two types of service, outpatient service or ICCMW, ECP, and for both types of service, the patient gets 1 year of service and no more. And there's nothing done to deal with the mental wellness. And how about integration into community? My colleagues have talked about this a lot already. What about support to family members? And how about home-based support? How about integration and reach out to the community, to the homes? And can we ask some crisis centers to deal with crisis instead of sending them to hospitals, and they would be discharged within weeks? According to the Bureau, we are going to convert some psychiatric hospitals into the care and attention home. This is against the international convention. Patients should not be excluded. If we have 1,000 of patients in Siulam, they will be living in seclusion, and that's a a second jeopardy. Next, we have Mr. Li Xion from Mutual Help, Hong Kong War Mutual Help Association. We have hospitalization and community-based services. They have been around for a long time, but demand is always far higher than supply, and the waiting time can be 2 years. If no one quits, then there's no way you can get the residential care. I don't know how they are going to deal with this problem. So please think about this. We have homes, residential centers there for more than 10 years. But I have never heard of any new one being built. Mr. Ng has talked about Siu Lam. But you know, Siu Lam is far away from the urban area, and it would take you an hour to take a feeder bus to go from Tsuen Wan to Siu Lam. So how can you cater for community needs? Are you going to ask these residents to live in a sort of isolated area, and then the problems will be resolved? I hope this is not the mindset of our officials. We are very unhappy about this Siu Lam proposal. Well, I hope to find out what other people think about this Siu Lam proposal. I would only say that I'm very unhappy about it. There's a need to build more mental hospitals. Because these hospitals always think about our interests first. Our mental health ordinance is seriously outdated. Well, it's really miserable. That's all I want to say today. Next. We have Mr. Wang Man-sun from Hong Kong Caritas Hong Kong. We have seen a spate of family tragedies. This goes to show that in planning for mental health services, the administration has done an insufficient job in support and prevention. So we have to think hard about certain issues here. Mr. Peter Zhang has commissioned Mr. Li Kam-seng of Polytechnic University to carry out a study of mentally ill cases who were involved in tragedies. Most of these people, these mentally ill people, receive care from doctors and nurses, but they were found to be lacking in family support, and there were insufficient community support and facilities. There were some pilot schemes implemented by the housing department to educate new tenants about the services provided by the community centers and homes in housing estates. But after those pilot projects, nothing formal was introduced. There should be more community-based home services covering not just new housing estates or new tenants moving in, or new people, new population in housing estates. We should ask social workers to identify the at-risk groups and to make suitable referrals such as employment services and services provided by ICCMW so as to prevent tragedies. And workers dealing with at-risk groups should be getting training in mentally ill related services. We should also involve teachers. Well, we have encountered cases whereby the teachers or the caretakers and family members concerned could not find out the risks, so suitable training should be provided. We should further develop the peer support so that emotional support can be rendered. I hope the government, in conducting the review, would pay more attention to preventive and community services. Thank you. Next, we have Mr. Lo Yok Kai from Hong Kong Human Rights Monitor. According to the UN Convention, the mentally ill should enjoy equal dignity and the right to receive medical help. And they should be allowed to live independently and participate in community affairs. Today we are talking about mental health policy and services. And the government is really not able to move beyond the medical-based approach. In Hong Kong, we suffer from a lack of medical services. But adopting a medical-only perspective is a limited perspective. It affects our ability and to comply with the UN Convention for the mentally ill. It's a narrow-minded approach. A medical-based perspective is a source of many problems. We would like the government to pay attention to the convention. I think it should be a human rights approach that we adopt in dealing with mental health policies, and this should be a holistic perspective. If we look at it from the perspective of rights, we will not be using terms such as the mentally ill, and we may use some terms such as the psychologically or mentally handicapped persons. They should be identified as early as possible, and there should be continuous and individualized service for them. And there should also be rehabilitation so that they can be reintegrated into community financially, economically, and also they can participate fully in choices that will affect them. And suitable support should be provided by the healthcare sector in making their own decisions, and they should be given sufficient information. And although their mental functions may be impaired to some extent, their potential can still be fully developed, so that they can make their own decisions rather than having some decisions imposed on them. And it's hoped that the community as a whole will take care of the employment needs and to support their family members and carers, and to help the mentally ill rebuilding their social network.
Next is Mr. Philip Wong from Alliance of Ex-Mentally Ill of Hong Kong. Hello, my name is Philip. I'm chairman of Alliance of Ex-Mentally Ill of Hong Kong. I would like to express some views on the proposal. we expect the HA to provide night consultation services for the mentally ill so that their work will not be affected. Previously, the HA undertook to start such, they said that it will be difficult to offer such night services, but it will be meaningful to the mentally ill people. We have been told by some patients who are living in hostels that they have regular visits from the CPMs, but they don't really ask about their situation inside the institution, so perhaps there is clear overlap of resources. So the resources spent on midway houses should be shifted over to the ex-mentally ill who are living in the communities. Now some personal feelings. My attending doctor said that I should try the new service with a case manager. I thought it is quite useful because I could inform the case manager of anything happening, and he comes to visit me every 5 to 6 weeks, and we will sit down and talk for 30 minutes. I can tell my manager everything, and the case manager will take my problems back to my attending doctor so that my doctor can more accurately assess my case. I go back to see my doctor every 4 months. I know that the service is only provided to the patients who recover from schizophrenia. I hope that this can be extended to other ex-mentally ill, especially those already living in the community. They need more support and more services so that they can live in the community happily. Thank you. Next, from Christian Oihip Fellowship Limited Executive Officer, Mr. Leung Mong Hong. Good afternoon, Chairman and members. We would like to provide all-rounded services to the mentally ill by upholding the spirit of the Christ. We would like to talk about education and discrimination. In Castle Peak Mental Hospital, well, actually in 2011 October, they conducted this survey, and 20,000 odd people feel that mentally ill people are violent. 25% of the interviewed are afraid to talk to mentally ill people. Half of the interviewed said that they feel embarrassed if they have to spend time with the mentally ill and the carers. 30% said that they will not tell people if they become mentally ill. It is obvious that there is still labeling from the public, and this labeling effect is slowing down the development of services for the mentally ill. And there is a gap between the mentally ill and the rest of the community. It is also preventing people who are mentally ill from seeking help, and therefore it prevents early treatment. According to CEO Hong Kong's report, in order to minimize the labeling effect, we first need to change the mindset of people. We need to change the culture. We need to promote positive images about mental illness. We also need to allow the public to understand more about self-control exercised by the mentally ill, allow them more opportunities to get in touch with them so as to remove stigmatization. If you look at the local curriculum, especially at the primary level, we're not teaching our students anything about mental illness. For a community that wants to promote harmony and mental health, it is a serious loophole. I urge the government or the Education Bureau to address mental health and importance of such education. As we all know, according to WHO data, more than 100 million are suffering from depression. By 2020, it will be the second killer on the list of diseases just after heart disease. In other words, mental illness is going to cause a lot of economic losses. According to Harvard, in September 2011, they wrote this report. For all the non-contagious diseases, mental illnesses are leading to greatest losses by $25 trillion US, and it is going to increase to from 2.5 trillion to 6 trillion in 2030. So what has the government done in terms of mental health education to remind people to pay attention and reduce economic losses? Thank you. Next, from Democratic Alliance for the Betterment and Progress of Hong Kong, Deputy Spokesperson of Health Services, Ms. Yip Pen. I'm the Deputy Spokesperson for DAB. Today's meeting was arranged a month ago, and within this month, some tragedies took place, and our community becomes more concerned about mental health policy again. Concerning such tragedies, I'm truly saddened, and at the same time, in terms of the policies being developed, I am very worried. As the WHO has mentioned, around the world, a quarter of the population has suffered from behavioral problems or mental problems. WHO also recommends that mental health policy should be incorporated into community health policies. Doing so will be able to help the mentally ill reintegrate into our community. We can also bring mental health to our community so that everyone is concerned about it. If we look at the recent tragedies, the mentally ill people involved did not know what they were going through. Perhaps they thought they just needed some medicine or go to the doctor from time to time. It shows that the administration is very weak in terms of early identification. Of course, it is related to the lack of manpower, so that the waiting time to see a specialist is very long. And the consultation time is very brief, as we all know. In order to communicate with the mentally ill, very often we need more time to understand what they are really thinking. So if you only get a few minutes, how do you really understand the situation? The DAB urges the administration to have a comprehensive system, add manpower, so that we can provide effective services to the patients. And we need to improve in terms of early intervention. Different people are suffering from different emotional problems. Students, employees, youngsters, or mothers. And there are different ways to assess mental illnesses. At different places, a questionnaire survey can be conducted, for example, in schools and also at mother and child's wellness centers, so that we can provide support to those who are under distress. This is also a good way to promote more knowledge about mental health and emotional problems. And of course, we want to promote mutual care at the neighborhood level. Thank you. Next, from EOC, Head of Policy and Research, Mr. Chu Chongman. Before I left my office, I checked the EOC website concerning how many times we have attended similar meetings. This is the 7th time. I have run out of things to put in my submission because I am just repeating myself. So this time, I have adopted a different approach to provide my submission. In the past 10 years, we have been fighting for the same thing, but actually the government has provided a framework and undertaking in 2008 when the International Convention concerning people with disabilities came into force, and Hong Kong has its responsibilities. Article 25 says that every person with disability should enjoy equal or the highest standard of medical services. But when there is a lack of manpower or services, for example, night consultation services, we've been talking about it for 1 decade. But you said that only 4.7 mental illness doctors are available for every 100,000 patients. That is not sufficient to provide care. The HA has launched some community assessment schemes for elderly people, but those who are living in elderly homes are not entitled. The convention also talked about social integration. Article 19 says that people with disabilities living in the community should receive equal protection. But when it comes to case management systems, ICCMW, and also the lack of midway house places, all these are preventing people to be integrated to the community, just like Siu Lam Institute. But the government is obliged to do what the convention says. And then when it comes to employment, according to a recent survey, their unemployment is 14%. For the rest of the population, only 4%. So it shows that they simply cannot find jobs. About social life, under the Bureau, there is this mental health review committee. And ex-mentally ill persons were not represented at the first meeting. They only found one for the second meeting. It shows that in the system, in the past, the views of the recovered patients were never taken on board, so it was very difficult to find the first representative. Concerning data collection, the government also undertook to do certain things, but it seems that you are just starting to collect views. I think the government has provided the undertaking, and you need to follow these standards and requirements. Next, from Labour Party, Mr. Lo Ho-yun. Thank you, Chairman. First of all, the Labour Party only sees a small number of representatives from the administration. We're very disappointed because it really involves Labour Department, Education Department, and Housing Department. But these departments or bureaus are not represented. Mental health is a social issue. It is not a personal matter. We should not blame certain people, but rather we need to reassess the service system. The Labour Party feels that right now different types of services are scattered around. Is there any collaboration among departments and bureaus? We need comprehensive mental health policy with action plan, budget, timetable, and manpower allocation. Compared to international standards, how many professionals do we need in relation to our population? We also ask for the setting up of a mental health bureau. It's been our request for a very long time. About the review committee, it was set up in May last year. It's been operating for more than 1 year. What has been discussed? Can we find out what has been discussed? Can you have more transparency? Are you going to do more public consultation? And then let's talk about education. We should remember a few years ago in this Tongchong school, Wang Lingfeng, a student jumped to his death. It was a tragedy that nobody wants to see. Mental health is not an area with extra support to the students in our schools at the moment. I think schools need to provide sufficient support so the teachers can do identification and support. We have been talking about the lack of manpower for many years. Waiting time for the mentally ill is very long. In some places, we're talking about waiting time of more than 100 weeks. For children with special education needs, they have to wait for assessment for more than 1 year or even longer. How can you then provide proper support in schools? What about collaboration between hospitals and schools when it comes to different services? We see ICNW without permanent addresses. That is not acceptable. Are you not doing all you can, or is it because of objection from the community? These are not to be seen as excuses. What about the frontline social workers? Do they have any more time to do further development and preventive work? We urge you to set up a proper mental health policy. Thank you. Next, Civic Party Health and Wellbeing Policy Branch Member Ms. Li Ka-ho. I'm speaking on behalf of Civic Party. We have always been concerned about mental health. If you look at the current mental health policy, we see that the HA has this 5-year plan, and we agree that we need to resolve many issues.
There's a lack of healthcare manpower. At the end of 2013, we only served 337 psychiatrists, compared with 2012. It was 334. It was an increase of just 3 psychiatrists. Of course, it lags behind the demand. If we look at the WHO requirements, every 10,000 people, we should have 1 psychiatrist. So if you apply this formula, we need 700 psychiatrists in Hong Kong. So there's a big gap here. If we look at the government's mental health policy, its focus is on healthcare services and associated measures. If we want to provide good mental health services, it's not sufficient. We need to have other social policies. For example, family-friendly employment practices, studies into the families of mentally ill, and mandatory employment of the mentally ill by certain employers, organizations. And we also look at policies about education and housing to help the mentally ill and their families. The Civic Party would like to propose that the government launch a comprehensive and long-term objectives be set. And there should be better cooperation among government departments to improve the situation. Relevant stakeholders, healthcare workers, carers, the mentally ill, social workers, schools and academics, and those who are concerned about the welfare of the mentally ill should join together and promote suitable policies to promote mental health. Next, Ms. Yun Suk Yan from SOCO. I want to talk about 4 things. The hospital authority has told us that there are new medicines, and they have switched to new medicines. But they don't tell us that there are also new injected medicines, and the HA is still using old medicines, which would affect the patient's chance to get employment. And for the mentally ill who cannot live independently, doctors and medical social workers tend to refer them to private homes, private hostels for the for people with disabilities. But these homes do not have any rehabilitation service. They don't have any professional people working there, and these mentally ill patients are just kept there I think we should pay attention to their rehabilitation needs. My colleague will be talking about this in more detail. Last year, Dr. Ko Wing-man said in this council that there will be a review committee set up with representatives representing the mentally ill. And then there was none. And then after repeated requests by us, they appointed some representatives representing the mentally ill. When they set the framework, they did not consult the mentally ill and their families. I hope the government can account and explain why the inclusion of family members and someone who are mentally ill do not mean that they are taken on board and the views heard. We have been asking for a comprehensive policy on mental health or a comprehensive document on mental health policy, and we haven't got none so far. We believe that every policy must be based in some sort of policy paper, so that we can follow up the relevant services, and we should not rely on piecemeal reviews. We asked last year of Dr. Ko whether there would be a paper. He said yes, but they were looking into the implications of issuing such a document. We'd like to ask the Bureau to tell us when the policy paper will be published, and if not, why. Next, we have Mr. Peng Hong Chung from Hong Kong Patients' Rights Association. We have counted the number of times since 2007 we have discussed mental health and policies, and this is already the 10th time. The deputations here and members here might have attended all the 10 meetings. We talk about the inadequacies in the system, the lack of appropriate services. And I would only say that progress has been very slow, let alone getting proper responses and measures to cater for their needs. Last year, Dr. Ko promised to carry out a review on mental health services and policies. We had high hopes. So now a year has passed, and if you take a look at the paper provided to the panel on health services, there has been no review on the service level. For example, how we can increase the services to the mentally ill, how new medicine can be used more extensively. Actually, these are about services. There's no need for the panel to follow up the issues. There are stakeholders out there who can do that. But we need to have a comprehensive policies based on sound values and principles. And we must have a clear objective, and that is to say we must set for ourselves the objective to be achieved within a certain time frame, and how we can do certain things in rehabilitation for the mentally ill. And we should have strategies, say within 5 years or more, what the administration and the community can do together to achieve certain policy directions. We need plans, we need strategies and policies. In 2011, this council has conducted a study of selected places. So I hope the review committee can do two things. When the review report is implemented, we hope there will be a document outlining the comprehensive policy, and we should have a 5-year plan so that we know the different government departments will work together to promote certain things, and also on residential care services. Some mentally ill patients cannot be admitted to the public rental housing estates. Some do not like to live in midway houses, so their service needs are not fully catered for. Maybe we should have a small home, say you group 3 or 4 mentally ill persons to live in a home setting, and suitable support will be provided to them to support their rehabilitation. Next, we have Ms. Chen Wai-ping from Concerned Group on Rights of People with Mental Illness. Thank you for giving me this opportunity to speak. I want to speak on behalf of people with mental illness. When I was ill, my family members accompanied me to see the doctor, and I found out that I only got 5 minutes in my consultation, and then the doctor will prescribe medicine, and we will leave the consultation room. There was little effort to understand what the patient had gone through recently, and then the attending doctors were not the same from one occasion to another. I hope the government will pay attention to such situations and make improvements. Next, Hong Kong Medical Health Council, Dr. Chen Chung Mao, WHO projected that depression will be the number 2 killer of human beings back in 2000. And then very soon it would surpass coronary disease as a major disease. The UK has promulgated this slogan that is, without mental health, there's no health. 15% or 500,000 people in Hong Kong have emotional problems. But unfortunately, we are lagging behind other places with a similar level of economic development. There's a lack of manpower. According to WHO standards, a psychiatrist will take care of 10,000 people, but in Hong Kong it's 1 to 12,000, and we're not going to catch up anytime soon. And HA is the main provider. There are 7 clusters. In 7 clusters, you get different levels of service. For example, the waiting time for new cases can be as long as 3 years. So apart from lack of resources, there's also unequal distribution. And some of the resources are used on rehabilitation. Very little is spent on prevention and promotion of mental health. Of course, if this cannot be done, then the cost effectiveness is affected. And there's a lack of comprehensive services. There's lack of communication between different organizations and responsible organizations. So we have a lack of comprehensive coverage. We don't have even distribution and sufficient manpower. Therefore, we have set up Hong Kong Mental Health Council. Many of our members have spoken today. We have invited Australian experts to come over to Hong Kong to advise us. I also went to Australia to learn from them. We have come up with a proposal to reform mental services in Hong Kong. I hope the government can learn from advanced countries such as Australia, New Zealand, the US, and Canada to set up an independent organization under the Chief Secretary for Administration, so that it would embrace a commanding view and take a comprehensive perspective in promoting and mental health and provide mental services. In other countries, they have a mental health commission with a representative from various walks of life, and it's much more representative than the HA and organizations offering mental services. That's the main reason why other countries are doing much better than Hong Kong in the provision of mental illness services. Next, we have Mr. Frederick Yeung from the Hong Kong College of Mental Health Nursing. Well, I have been talking about the same thing over and over when I attended past meetings. I wonder whether I have anything new to say. I will just be repeating points already made by other deputations. We want to have a unified and consistent policy direction. The HA has done a lot. It has done a great job. But they are mainly dealing with people with serious mental illnesses and their rehabilitation. But mental health is not just about those suffering from serious mental illnesses. Rehabilitation is not just rehabilitating of the patient. We want to cover all service recipients. So apart from categorizations by illnesses, we should look at mental problems suffered by different groups in the community. Recently, we have had some problems with cross-boundary students and new arrivals, new immigrants. In North District of the NT, many women are suffering from depression because of marital problems. And then recently there are problems caused by cross-boundary students.
So are we to react when problems emerge? We always attach importance to comprehensive policies that will cover everything, so that we don't have to present our cases in a piecemeal manner. So the government or the HA would tell us, we already have certain policies or services, but how do we reintegrate everything? When it comes to institutions or community-based recovery or services, since people would like to stay inside their own community, they should receive services there. The hospital is only a temporary facility. So we need something more comprehensive and not scattered around. If we have more comprehensive mental health policy, we can do things step by step. That is not available at the moment. Some other speakers talked about nurses providing triage services. That should not replace the work of doctors. We need to offer help to different patients with different needs. And nurses are very important in providing suitable care to the patients. All the deputations have spoken. Secretary, would you like to respond? Thank you. First of all, I would like to thank all the deputations and individuals Thank you for coming to provide your views again. I have heard that you have been here quite a few times. And of course, the government has set up a review committee concerning mental health. And we have done a lot of consultation work. Some of the representatives here today, well, actually, I have already met with you before. Our committee is doing its job, and it has been meeting for a year. Last time, I think around April, we came back to the panel to report on our progress. At that meeting, I remember some members suggested that we should collect views from different groups again. So thank you very much. Perhaps I can respond to the issues or questions you have raised. We need mental health policy or the setting up of mental health bureau. That is a common request from many speakers. At the first meeting of the review committee, we discussed in great details about these issues. The government always attaches importance to mental health of the public, and we provide consistent cross-disciplinary, cross-departmental mental health services. If we just look at the services, perhaps they seem all scattered around. But behind the services, there is this framework that covers prevention, early identification, treatment, timely intervention, and rehabilitation. So in terms of consistency, at the committee, we've also considered different groups. Under the committee, we have a number of working groups to consider different issues. For example, elderly or youngsters, mental health among adults. Last time I came back to report on mental health issues concerning adults. Perhaps you have talked about international indicators, or do we need a cross-departmental bureau? The review committee is led by a bureau, but actually we have invited the Education Bureau, Labor Bureau, and SWD colleagues to participate. And we understand, in order to have a comprehensive mental health policy, we need to involve different sectors and different departments. We would like to explore different issues and review on different matters with the participation of different bureaus and departments. And of course, we will continue to report to the administration all your concerns. When it comes to taking care of the mentally ill, the carers, or aging of the carers for mentally ill, we have heard your suggestions, and we continue to stay very much concerned. Mr. Young talked about the nurses. Perhaps you feel that there is triage services provided by nurses so as to resolve the shortage of manpower at the doctor's level. It is actually not true. Mental health nurses have gone through the necessary training, they have experience, and when they carry out assessment, they use tools that are standardized tools, and they are not done independently, but carried out by the whole team. Some people talked about the importance of prevention. We totally agree with that. So we hope to step up education so that people will be more tolerant, they're willing to embrace mentally ill. And finally, many of you talked about shortage of manpower. I would like to reiterate, in terms of manpower, there is shortage at various levels. We will continue to provide professional training at different levels. And we will also consider the mental health discipline. And we understand the need to increase manpower. Some of you have talked about issues surrounding the HA. Dr. Zhang is here. Do you have anything to add? I think today we have looked at the matter from a macro level or in a systematic manner. I've been to many similar occasions, but today we have collected very good views. Our system is by no means perfect, but allow me to respond to some issues presented. We talked about peer group support. Actually, we already have plans to hire ex-mentally ill people who can then assist case managers to provide support to the currently mentally ill. They will be proactive and they can share their real-life experience to show that how to walk down the path of rehabilitation with the help of family members. We will consider the recruitment situation and extend the scheme. Secondly, we talked about PPP. I think the most important thing about PPP, how do we incorporate support for mentally ill in our system? We're not just talking about the mental illnesses. We're talking about the chronically ill or people with financial difficulties. They all need support. And we're not talking about specialist level services. We can deal with them at the primary care level. So if we can develop this more proactively inside the system, specialist services can be extended to shorten waiting time or extend consultation time. We continue to face shortage of doctors, and as for nurses, there will be more nurses coming out in the coming years. We'll also rely on professionals like clinical psychologists, social workers, and occupational therapists, so on and so forth, so that we can involve different departments and disciplines to resolve this. I also agree that when it comes to mental illness, it is not a medical issue alone. If we have a medical-led approach, it may not be the perfect way forward. The committee will continue to review our way forward. I really appreciate your views every time I'm hearing something new. Under Secretary, anything to add? No, nothing to add. It is now 7. We need to end at 7:15, but 7 members are waiting. So we don't have enough time. We need to extend by another 15 minutes.
間斷大家嘅發言。咁我攞到個次序係黃碧雲、何俊仁、郭家麒、張。
We have now the following member who would like to speak: Dr. Helena Wong, Dr. Kwok Ka-kay, Mr. Poon Siu Ping, Mr. Peter Cheung, Dr. Wong. Recently at Kai Ching Estate, there was a shooting incident. Someone was murdered. And then there's another case where the mother killed her daughter. I convened a residents' meeting after the Kai Ching Estate incident. Some residents asked me that since that person was suffering from mental illness, why was it that the social worker's report said he was okay and he was given a flat in a new housing estate where he could not find any support and services because no center had been set up there? Well, we cannot really ask why that social worker said he was okay. Well, that person was imprisoned because he had chopped someone's fingers. I cannot blame the social workers. I heard that every social worker has to deal with 60 cases, or they have to handle 100 or so people in need of assistance. So the question is, with the manpower level so low, how can the assessment be adequately done? So it may be difficult to assess whether the person has fully recovered. And then a recommendation made to the housing department that he be allowed to live in the community. I thank Dr. Chen Chung Mao and others for pointing out the problems with resources, manpowers, and the uneven distribution, and the wrong focuses, and the lack of coordination of services. Maybe the Bureau should respond. According to your document, patients with serious mental illnesses are being followed up by HA. 205,000, and we have around 70 to 200,000 with mental problems. But it's also said that we have 1 million people in Hong Kong with mental problems of different levels. So maybe you are just catering for the most serious cases. So can you respond to the allegations that there's lack of coordination, or you are putting money in the wrong areas? Let me respond to the point about what would happen. I will ask HA to respond to the point about what would happen to those with less serious problems. HA is now taking care of about 200,000 patients with mental illnesses. The serious cases are those with schizophrenia, and the milder ones are suffering from depression, and so on. And how many people in Hong Kong have behavioral problems or mental problems or depression? Well, I myself may be suffering from depression some of the time, but it doesn't mean that every one of them is a mentally ill patient. Mr. Albert Ho, I would like to thank all the deputations for taking the trouble to come again and again for so many occasions in the past 10 years and to raise their concerns. But so far, we haven't seen any satisfactory improvements. We know that these are pressing problems. In 2020, depression may be the #1 killer. I thank the deputations. They have taken a very macro perspective. Some look at the services from a professional point of view, and they have talked about all sorts of problems in the community. Although the Undersecretary and Dr. Cheung have responded to some of the points, but there are still outstanding views not responded to. The deputations have raised many issues of different levels. For example, we need to have a mental wellness authority. We must have a strategy. We must have a policy document. We must improve medication, and we should have some performance pledge for follow-up consultations, and we should do more in public education and liberal studies. We should let people know more about mental illnesses. If you hear things, it may be a symptom of schizophrenia. Many people do not know this. And we also want to improve outpatient clinic. We should have night service. Maybe we should come up with a checklist. We have done this in our bills committees. We would compile the points raised by the deputations in the form of a checklist. It's hard work for the Secretariat, and I propose that we give the checklist to the government and ask for a response. If they cannot do it, they should explain. For example, why can we incorporate some of the proposed contents in our textbooks? Many people are so concerned about the problems. The government should appreciate the importance of these issues. It's a joint venture for all. We should not back down just because of the need to do a lot of hard work. I think it will only be fair to all if we provide the checklist and ask for a response, and we will be willing to help in the preparation of the checklist. Dr. Kwok Ka-Kee, I've heard from Dr. Chu that he lamented that we have talked about it for so many times. In 2007, I was the first one to raise it. The last secretary whiled away the 5-year term, and now we have a new secretary. I thought he would be different. Last time it was Dr. York Chow. Well, he put up a show and sat there to listen to us. But this secretary doesn't even have the heart. In EU, it's said that the resources will be pegged at 1% of GDP, Australia 1 to 1.5% of GDP. We are still spending less than 0.25% of our GDP on mental illness-related services. All the review committees that they have formed is there for filibustering. At first, they didn't even have any representative from family members of the experimentally ill or experimentally ill person. And they talk about comprehensive services. Do they have anyone from the SWD or from the Education Bureau? I think our questions are very clear. We would like to have a commissioner on the rehabilitation of the experimentally ill, or we want to have a commission set up. And does the government has any clear objectives? Well, you can waste our time. You can conduct one review after another. Please don't waste our time. I don't think we should just let them off the hook. Let's say they don't know how long the process will take. But Chairman, let's ask them for a report in 6 months' time. And let's have the chairman of the review committee with us. Last time, Dr. York Chow was with us the whole time. Then the secretary is not here. That's not a sign of respect. I don't think you need a response. Okay. Well, I need a response, Chairman. Okay. Please be brief. I have to clarify a point. The review committee on mental health has a clear objective. We have working groups. We're not doing any filibustering. The different working groups are working on different things in earnest. Of course, in April, we came back to report on the progress. The The progress was in relation to the adult mentally ill persons. And of course, other working groups were at the same time working on different things. We hope we will be able to come back to brief members on the progress later. We need clear objectives. Mr. Peter Cheung, I'd like to thank all the deputations and individuals. I'm not an experienced member here, and I've seen you a number of times. And it's remarkable that Dr. Cheung said that we all adopt a macro perspective. Because not many questions are related to new medicine or night clinics, and many deputations have spoken on the need to set up a commission or an authority. Mr. Chow said many social workers only cared about figures. It's not that the social workers care only about figures. The government wanted certain number of cases to be handled, and the figures are staggering. For every ICCMW, it's 9,000 cases of outreaching cases. Performance is judged by figures, and it's at odds with our job nature. We work with people, but there's no way you can ignore it because funding depends on it. It's a systemic question. I thank Mr. Chow for pointing out the problems. I agree that the issues raised today cannot be handled one by one in any easy manner. Even if the review committee has come up with any recommendations, the recommendations can easily be shelved. So I agree with Dr. Chen that if we don't have a commission or authority on mental health, there's no way we can press for the implementation of the recommendations. But if we set up a commission, it's going to cost a lot of money. And it takes more than one bureau or the HA to handle all the issues. On some issues, we need the Education Bureau, the Labor and Welfare Bureau, and in some cases, we need to coordinate with the SWD or the police to handle incidents. It seems that when there's no incident, we are all happy to sit here and talk. But when there is an incident, we're just eager to find out who is to blame. But anyway, we need to take the first step. Even if we don't have an authority or commission, we should have a steering committee to coordinate the work of various bureaus and departments. Undersecretary, please be brief. Your views have been noted. Now that we have this review committee on mental health, it's a structure that we can rely on to get things done, and there are representatives from different bureaus and departments. If we are to implement services in various fields, we need coordination. So we hope these representatives will be able to help us coordinate and implement the necessary measures, and then we can be more. We can talk to each other in an interactive way. Actually, there are deputations who have mentioned night clinics. Maybe Dr. Zhang would tell us that the demand is not great. But for those people, those mentally ill people who hold jobs, they need night clinics. I don't expect you to offer it in all the districts, but at least you should have some clinics in convenient locations. For example, with clinic hours running from 6 to 8 p.m. because the employed mentally ill people may be reluctant to ask for leave for follow-up consultation. If this cannot be done, how can you achieve community rehabilitation? You have tens of thousands of people. There are more than 10,000 people in residential care. And there are 40,000 suffering from serious mental illnesses. Your case manager can only take care of 17,000 patients, and there are still 10,000 living in the community who are not cared for.
So on a macro level, we can have the Mental Health Commission, but before that, or can we do something at other levels? For example, more services at the community level to support rehabilitation. I've heard that when you don't have the resources, you don't have the manpower, or the government doesn't care, it cannot be done. Can we strengthen case management? Will you allow more resources to go to the NGOs to follow up? More than 10,000 severely ill can recover in the community. I'm sure everyone here would like to see that happen. So I understand that people or government officials are moving from post to post all the time, but we need more resources to support rehabilitation. Make it brief. You are right. We have this review committee to deal with long-term issues. And perhaps Dr. Chen can talk about other support services. I just want to talk about night consultation services. Yes, we understand your demand. It is reasonable. But it involves shortage of manpower and long waiting time. Non-urgent cases have to wait for more than 1 year. So we would like to tackle the priority issues. Concerning night consultation services, we're not saying no, but it's about when should we do it. But Dr. Zheng, what about PPP? We will discuss that if we have more time. We want to thank all the deputations for coming. If you look at the document from the administration, relevant resources for mental health has been enhancing. For example, 3.75 billion in 2009, and then it increased to 5 billion in 2000, so on and so forth. How do we set the indicators to better use our resources? If you look at Annex A, $15,000 hospitalized mentally ill, 650 of them have to be provided with long-term care. So more than 1 year, 650 people. Is it a stable number or is it increasing year on year? 3,607 mental beds have been provided by the HA. So 650 need long-term care. 3,000 are left. I would like to know why the utilization rate is only 70 to 80%. You talked about renovating Kwai Chung Hospital. Do you have real options or plans? And the Secretary, Dr. Chung, will respond. Dr. Chung? Thank you for the question. Allow me to take you through the figures. Right now, 3,600 odd beds under the HA every year. We're talking about people discharged. We're talking about 17,000 odd such cases. For those who have been hospitalized for a long time, they are called long-stay patients. Because of poor treatment, they have to stay inside the hospitals. Because of more institutions being provided to the patients, the number of such long-stay patients have been reducing. But today's medical treatment has been improving. No more follow-ups, right? Next, Ms. Kapufan. Thank you, Chairman, and thank you all the deputations for coming to provide your views. I understand that you have come many times and you just repeat yourself. I feel very sad. The administration's paper presents progress, but only progress on paper. Many of our colleagues have talked about policy follow-ups or asking for checklists to be set up by the government. I heard from many people that prevention is better than cure. We need family-friendly policies other than providing timely support to those who are ill. We need to identify them first, of course. On top of that, I do not see the government's paper talking about prevention or community education so as to promote healthier lifestyle in Hong Kong and reduce the number of sick people. Can the government do more? Who would like to provide some further views or more views afterwards? Many people thought that depression cannot be prevented. There's no vaccination. Actually, in many advanced countries such as Australia, they've done a lot of research and a lot can be done. You can do more exercise. You should exercise for 30 minutes 3 times a week. Social activities or stay under the sun are very useful ways to prevent depression. So a lot can be done in terms of prevention and education, but they are not being done, especially when it comes to treatment. You can only spend a little bit to get very good outcome in terms of prevention. Yes, indeed, we don't really talk much about prevention. For many years, number of mentally ill continue to increase. Perhaps it's because we know more today and we identify more people. But it is quite alarming. Is the city ill? What can we do more in terms of prevention? Because prevention is better than cure. We don't see any plans or dedicated working group being set up to discuss how we can do prevention so that we are more healthy and happier. I know it's a huge topic. Just like many experts have said, it is something that can be done. So I would like to see the government set up a working group to handle or study how we can promote mental health to avoid depression. Thank you. Under the review committee, we do talk about prevention and public education. So we will continue to follow up along that line. I won't pick one for the second round. Thank you. Thank you, Dr. Chung, for confirming with me the number of mentally ill cases. You are following up on 250,000 people, and 30 to 40 are seriously ill. But I am even more scared now. According to the Mental Health Council of Hong Kong, page 1, second footnote, they said the general assessment is that for seriously mentally ill patients in Hong Kong, it is between 70,000 and 200,000. And these are severely mentally ill. Let's say it's 70,000. You think it's 30 to 40,000. What is happening to the 30,000 who are missing? Who is following up on them? Are they seeing private doctors? Do they even realize they are severely mentally ill? They are in our community. How do you identify them so that we can help them? Otherwise, this is a huge time bomb in the community. Community-based rehabilitation is not realistic. That was said by the representative from Hong Kong Chinese Civil Servants Association. He said that we should not use community-based policies in Hong Kong. Can you respond to that? Thank you. Community-based rehabilitation policy is a world trend. We understand the colleague from CCSA said because of the crowdedness in Hong Kong, it may not be suitable. Yes, we will review that, but we are not launching this approach just because we want to reduce the number of beds provided. Under the hospital authority, there are committees discussing different treatment modes. And when it comes to rehabilitation, treatment, early intervention, they continue to discuss the model. Dr. Zhang, do you have anything to add? It is not appropriate for me to comment on one point presented by one individual. Perhaps he has relied on some foreign calculation, and we're talking about serious depression or schizophrenic patients. Perhaps we are looking at different definitions. So the seriously ill, what is the definition? Perhaps we need to ask that association. That is based on HA Adult Mental Health Program data. It was not something he invented. Perhaps he misunderstood something. I need to go back to the submission. If they are referring to our document, I will give you a written reply. Other members are still waiting to ask questions. Without objection, I will extend the meeting by 10 more minutes, okay? Mr. Albert,
we are all concerned about manpower planning for the future. Services are inadequate because there are not enough psychiatrists, serving in the HA. And there's also a lack of allied professionals, healthcare professionals. There's insufficient clinical psychologists. And there is also a acute shortage of psychologists in the private market. People are asking for service standards up to the required level. Without manpower, how can you achieve the required standards? For example, waiting time is impossible to achieve because you don't have sufficient people, and you can only give each patient a few minutes for each consultation. And there are also so-called hidden patients who may have a risk of relapse. And you may have to resort to a medical order to mandate consultation. Of course, it's not desirable, and because it requires a lot of manpower. We have raised it for 5 or 6 years already. You want to carry out community-based rehabilitation, and many patients have been discharged into the community. Of course, it's a good thing, provided that you have sufficient supporting measures. Chairman, I don't think they can answer all these questions. So let me make one final point on how we can follow up. I request that the issues raised should be responded to in writing. I don't know whether they need to have a list compiled. I hope we should follow up with multiple meetings to achieve effectiveness. I'll talk to our Secretariat to see if we can produce a list. Well, I can help if help is needed. Dr. Helena Wong, I have a follow-up question. I agree with Mr. Albert Ho's suggestion that let's prepare a checklist, and also for our meeting minutes. We may wish to inform the request the Education Bureau to respond to educator-related issues, and we should also reflect views about excessive workload or to the Labor and Welfare Bureau. It's unfortunate that we don't have anyone from the two bureaus here today. Let's reflect the views to them. We still have one more item to handle. I would like to thank all the deputations for their attendance. We will take appropriate follow-up action. You may now leave. Do we need... Oh, okay, we don't need the officials either. We have one more item on Chinese medicine. 2 minutes would do. This is about setting up a subcommittee on issues relating to the development of Chinese medicine. The Secretariat has prepared a document for us setting out the work plan and the terms of reference. The paper has been circulated to members. And after listening to members' views, then we can approach the House Committee, right? We can join the queue. Mr. Chen Hangban asked me about this. whether they can only give us views by physical attendance. It's not necessary. They can do it in writing, and if you have got further views to make, you can supplement your views in writing. And then the subcommittee will have a discussion on the terms of reference after it's set up. We have another one on health protection scheme, another subcommittee. And there's still some outstanding issues. The detailed proposal for the healthcare protection scheme, the assessment on manpower needs. So the subcommittee on healthcare protection might only be able to wrap up its work in November. And it seems that under the panel on health services, we can only set up one subcommittee. We're allowed two.
我哋已經有兩個小組，另外一個係長期護理政策。
And we've also got another one on long care health services. Okay, so let's see which queue we would like to join. Please take a look at the proposed terms of reference and work arrangements. Comments? I just want to say that I support the setting up of a subcommittee. Let's see if we can join a queue, a quick queue. We can discuss the terms of reference later. Other members, any comments? What choices do we have?
我諗 check 長期護理嗰個佢做會咁排。
Check when the subcommittee on long-term healthcare can be wrapped up. There's nothing under AOB. Meeting's adjourned.